Thanks, Axel and Dave Wilson for the kind invitation. And I know you think, the worst thing of being the last person of the day is that everyone's hungry and tired and wants to go see Hamilton and not listen to me. But the worst thing is actually when you realize that probably half of the slides that you've done have been trumped repeatedly over the course of the day. So some of the stuff I'll go through a little bit quickly because you've probably heard a lot about some of these things already. But I'll spend a little more time at the end because my expertise is really in the hereditary risk evaluation, and you probably have heard a little less about that. And that world has changed a little bit. So hopefully I can get this to advance better than Chris Lude could. Could I go to the next slide, please? Oh, great. So just my outline, a little bit on somatics, a little bit on germline, a little more on germline actually, and then a summary. Next slide, please. So the somatics of GI tumors evolving world. Next slide, please. So this is just, we still are kind of at a dearth of targets in GI cancers. Some of them like, KRAS, NRAS, we are checking routinely now in colorectal cancers, in gastric, gastroesophageal, HER2 definitely. MSI is clearly, I'm sure you've heard a lot about as an emerging target, which will almost certainly become standard of care soon. There's currently an ongoing clinical trial, the AZ Polo trial for BRCA1/2 as potentially a germline target that will predict therapy in tumors. mTOR is a biomarker or a sort of a target of sorts in neuroendocrine tumors. And then there's certainly a lot of things under evaluation, which Chris Liu and many others I'm sure today have gone over, some of which certainly will hopefully pan out, like IDH1 in cholangio and potentially HER2 and other targets in colorectal cancer, but many of which will probably not pan out. So we still need more. This field has interestingly moved much faster in other tumors, perhaps like lung, but I thought some of the points that were made earlier, especially that the harder we look, we can find these novel small fusion events, which will likely pick up a lot more targets that we'll be able to throw agents at in the future. So in the colorectal world, this was a great paper that I think really started to kind of get us thinking about MSI and certainly then ASCO this past year, and I'll cover this quickly, really kind of brought MSI onto the windshields of people who probably really weren't thinking that much about it, except people like me who worked with Lynch syndrome for the last 10 years. But what this paper showed was kind of divided colorectal tumors up into these mutated, non-mutated tumors, and then this small ultra-mutated set that I'll tell you a little bit about in a couple slides. And what was interesting about this is, the genomic mutation burden was much higher in these hyper and then these ultra mutated tumors compared to the majority of tumors which were MS stable or non-hyper mutated. And what I show at the right is also when we looked at the targets or some of the other mutations in these tumors, things like APC, P53, which have been classic and we've known about in colorectal cancer for a long time. That mutational profile is different in this subset, and we know now this subset of these mutated hyper or ultra mutated is probably roughly about 15, maybe 20% of colorectal cancers at best. So these were a different type of tumor, and really these data I think were important to lead into the events that occurred then in the last couple years, which have been exciting. If I could get the next slide, please. So again, I'm sure anyone who attended ASCO knows the excitement of this story, and probably it's been covered. I arrived a little late today, but I'm sure it's been covered. But just 2 sentences about the data presented by Young Lei in the New England Journal and at ASCO this past year, and at GI ASCO just a few months ago, showing that these microsatellite unstable tumors or these hypermutable tumors appear to have great responses, or at least much more robust responses than their MMR proficient colleague tumors. And the PR rate, the stable disease rate, when you added these things all together, the disease control rate in the MSI high tumors, colorectal cancers, at least in this first publication in New England Journal, was as high as 90% compared to the MMR proficient, which were quite low, around 10%. So, and they offered us a little data in this first publication, which I'll get to in a minute, of what was updated at GI ASCO this year. But clearly MSI, both within colorectal cancer and outside of colorectal cancer, is going to be an emerging great target for immune therapy. Next slide, please. So, my colleagues at Fox Chase always make fun of me because being a Lynch syndrome person, I've been talking about MSI for 10, 15 years, and everyone was sort of tired of hearing about it until suddenly it came onto the scene as a target for therapy, and everyone's suddenly interested. So we had to go back to the old data and say, well, gosh, has anyone looked at in some of the other GI tumors like gastric, hepatocellular, ampullary, what are the rates of MSI in these tumors, and potentially even outside of colon cancer, is MSI in and of itself going to be a great therapeutic target? And so these are some of the reported rates of MSI from the literature, in gastric maybe as high as 22%, lower rates in pancreas, anal, very, very low rates, but probably a few here and there. Small bowel is actually quite high. On the right, I just put some data that my research group presented at ASCO, at GI ASCO this past year. We took a bunch of data from Foundation Medicine, who had done screening a large genomic profile, on many thousands of patients, 15,000 patients, and we developed actually a particular MSI detection protocol using the data that comes out of that test, and found these rates. So our rates were a little bit lower than had been reported in the literature. Some of that is probably just because of the selection bias of the kind of patient that gets a large genomic profile. But I think what we did find, and we'll be presenting at ASCO coming up in a few months, is that actually across a large span of tumors, everything from sarcomas to, again, anal cancers, you name it, there's a small rate of MSI there. And I think Chris Liu made a good point that this is probably going to be one of those trials where we need a catch-all trial, that if you're MSI high, no matter what tumor you have, should there be the trial available where you get an immune therapy. And I think that would obviously be very exciting, and is likely already in the works outside of GI and in any kind of tumor. Again, at ASCO, this GI ASCO just a couple of months ago, Young Lei updated her data to show us that there have been responses outside of the colon that are in MSI high tumors, so in ampullary cancers, pancreas, biliary. I mean, tumors that are traditionally often quite resistant to chemotherapies, PRs, CRs, and some very nice responses. So I thought what was really impressive about some of the data she showed was, there was actually a gastric tumor, an ampullary, a cholangio, where there were almost 100% reductions or close to CRs in these tumors, which was pretty outstanding. So what's next? What I just said a couple minutes ago, I think some sort of studies that are actually going to use MSI as the criteria to enroll patients in a study of immune therapy, potentially a paired study of immune therapy and another agent. I think this will be really exciting, and these kinds of trials would probably be most interesting if they enrolled patients from across the spectrum of cancer, as long as you can demonstrate that they have instability, genomic instability. There's also a phase 3 trial which is now rolling around the country that is going to randomize individuals to frontline chemotherapy of choice versus immune therapy for MSI high tumors. So this is the Keynote trial, and I think this will be, actually extremely exciting if we see that for MSI high colorectal patients, if we see that actually frontline immune therapy is actually superior to starting with chemotherapy. So that'll be a story to be continued. Next slide, please. The other trial that right now in GI is particularly, or phase 3 trial I should say, is particularly targeting a genetic event per se, is the POLO trial, which is looking at elaborate maintenance. And this is actually in patients who are BRCA1/2 germline carriers who have unresectable pancreas cancer, which has responded to a platinum agent. It's a bit of a complicated trial. Accrual has been slow because there's sort of a lot of things that the patients have to fit. They have to have BRCA, which is roughly only probably about 5 to 10% of pancreas patients at best, and they have to have responded to platinum. But I think this is an interesting study design and an interesting concept in that these PARP inhibitors, as we know, olaparib is already approved in ovarian cancer for nth-line ovarian. So these PARP inhibitors play on an intrinsic weakness within these tumors, this inability to conduct homologous recombination double-strand break repair. So I think this is an exciting area, and again, this will be a story to be continued as this trial accrues. I just provided here just a schematic of the sort of the mechanism of how PARP inhibitors sort of prey on underlying single-strand break repairs in these tumors. It then blocks the homologous recombination double-strand break repair that is already deficient in these tumors because of BRCA1/2 deficiency. Of course, one thing we do know from the literature for a long time is that tumors are smart, and they do learn how to reverse the mutations that they inherently have in their BRCA1/2 genes. So these therapies will certainly be imperfect, but potentially can buy patients more time, and perhaps in combination can be more lethal to tumors. So I think I'm going to spend just a little more time, because I think some of that was probably a little bit of review for everyone here, but a little more time on what my particular area of expertise is in germline genomics and evaluation. And before I start that, I'm going to take this slide, which is sort of at the middle of my talk, to say that I think sort of one other exciting world out of or exciting change out of the genetic and genomic testing of tumors that kind of crosses over with this hereditary testing world is that ASCO in August came out with new guidelines for how we deal with genetics and genomics issues. And in these guidelines, the recommendation is now that patients who are having these large multi-gene profiles of their tumors, that we need to actually be disclosing to these patients that there may be actually important hereditary implications of testing genes like P53 and APC and some other genes that have hereditary implications. So this is actually a change from ASCO policy before, which kind of just didn't really address that issue. So I think there's sort of a lot of thinking and questioning about how we're going to actually spend that time, who should actually be spending that time with patients. Do they all need to have genetic counseling before their 300 gene profile? I think that's probably not going to work in terms of the labor force and the amount of time patients want to spend, but I think it's an important issue, and we will see where that goes. There will be, my group actually wrote a review article about this that'll come out in JNCCN just in the coming months in June, that'll kind of give people sort of an initial understanding of these emerging issues. So what are some new genes that have hit the hereditary GI world? So I think the most perhaps interesting ones are what everyone is calling the POL genes, and these kind of refer back to a slide I showed a minute ago. So POL-E and POL-D1 are short for polymerase E and D1, and these are DNA polymerases that in the dividing cell are working on the leading for POL-E and the lagging strand, POL-D1, of a dividing cell. What Pallas and her group and several other groups around the same time were showing were that germline mutations in these genes actually lead to this actually hypermutable phenotype with accumulations of 5,000, multiple mutations in a tumor genome. So, and Pol E with actually even a higher mutation burden than Pol D1 in tumors. What's interesting about Pol D1 is in those cells where it's the lagging strand of mutation, actually the microsatellite repair system, the mismatch repair system actually repairs some of those mutations that occur because of malfunctioning Pol D1, so they don't tend to have as high of a mutation burden. But nonetheless, what Pallas showed was that these genes were associated with a new kind of phenotype that they called PPAP, so proofreading polymerase associated polyposis. There's a very highly variable phenotype with these genes. What they showed is that there are certainly individuals who have a hyperpolyposis that's reminiscent of APC. There's kind of a mid-range polyposis that's more reminiscent of maybe an AFAP or MYH. And then there do seem to be individuals who just have maybe early onset oligopolyposis, 2 to 3 polyps in their 30s or 40s. So I'll just say that I think the phenotype is variable and is still being defined. The prevalence of these mutations is variable and still being defined. I'm going to show you some data in a slide or two that early on showed that was kind of a shock to everyone in the field, that showed that maybe the prevalence of these things was as high as 2, 3, 4% in Amsterdam type families that fit high-risk criteria. I think that was probably an overcall at this point, but again, this story is still evolving. One thing that's interesting about Pol D1 is that individuals with these mutations, and you don't see this in Pol E, they also seem to have endometrial cancer in these families, which again kind of then makes you think back, for those of you who are Lynch syndrome fans like me, of Lynch syndrome. You know, why colon cancer and endometrial? What is it about those two tumors that would cluster in a polymerase and a DNA repair type gene mutation? They've also found in these families brain cancer, ovary cancer, a few others, but again, the total number of families that have been identified is pretty small right now, so this is kind of an evolving story. So these are the data that I was telling you about from Spear and from Belindo, looking at some of their high-risk cohorts. You know, essentially when these genes were discovered, then everyone ran these through their multi-cohort families of families that fit Amsterdam criteria, that they didn't have mutations identified yet, and at least Spear found that 4% of these families had Pol mutations. So that's high. I think that's probably higher than reality because these were select families. They found that families with just unexplained polyposis rates were anywhere from maybe 2 to 7%. So again, this is not a rare mutation, or these are not rare genes, at least from these data. Belindo published a couple of papers after that, which showed somewhat lower rates, again 2% in these Amsterdam high-risk families where you have multiple colon cancers, 1% in microsatellite stable, non-polyposis but early onset. So again, speaking to the variable phenotype that we're seeing with these genes. So even in that group, 1%. So 1%, just so you know, that's actually more common probably than APC mutations. So these things are, while they're rare, they're not that rare. And I think in the next couple years, as we do a lot more sequencing, these genes are now on some of the common hereditary colon panels that are being used in our clinics. So we're going to have a lot more data in the coming years about how common these are. Next slide, please. What I thought has actually really been interesting as well in the last couple years, and this has really come about because of the way we're testing, which I'm going to get to in a minute, but what I like to call old genes in new places. So, you know, we all went to medical school, and what we learned about P53 was that this is a gene in the germline that when you have it, it's really bad, and it's associated with a bad syndrome called Li-Fraumeni, where people get lots of different kinds of cancers at an early age. They tend to die of these cancers at an early age because they develop multiple cancers. These families, you know, traditionally we thought of as being highly penetrant. Again, everyone in the family who's a carrier gets cancer dies early. So what these panel tests, which is now we're sort of conducting gene panel tests on almost every breast cancer patient, almost every colon cancer patient, you name it. Everyone targeted testing for hereditary cancer risk is kind of starting to go away essentially. And if you come in with colon cancer at age 40, you're probably going to get a panel that includes anywhere from 15 to 40 to, who knows, 70 some hereditary risk genes. So what we're finding with this is that the phenotype that we thought we knew of P53 is probably actually a lot more diverse and, as I like to say, softer than we thought it was before. So there are people who simply have early onset colon cancer who, when you sequence them, you find that they have a germline P53 and they don't have a family that's riddled with sarcoma or leukemia or other things. So these mutations are not as penetrant as we thought and have a phenotype that is different than we thought. So Matt Jurgelin from Dana-Farber presented some nice data at a couple conferences, ASCO and GI ASCO, Hereditary Colon Cancer Group, and published in JAMA this past year, showing that in the International Colon Cancer Family Registry, which is a big consortium of a bunch of centers that basically do population-based and clinic-based ascertainment of patients with colon cancer, what they found there is that they targeted colorectal cancer patients under the age of 40, the rate of germline P53 was about 1.3%. So, I guess sort of at face value you could say, well, that's not really that high, but again, this was a syndrome and a gene before that we really thought of as being quite rare and again associated with a very strong phenotype, and these individuals did not come from families that were known or had any phenotype that looked like Li-Fraumeni. So that was quite an interesting finding. Like I say, at the bottom of this now, basically almost every hereditary colorectal cancer patient we see at Fox Chase, and I'm sure at many other centers, gets tested for P53 because of this, because these genes can be added onto these hereditary panels quite readily and quite easily. So again, this is the phenotype of this gene is sort of evolving with time. Another gene that has been extremely interesting in the last couple years and is probably one of the toughest genes in terms of my practice in a high-risk clinic has been the CDH1 germline gene, and a couple of those questions that popped up before we started this came, I think, from me. But so this is a gene that traditionally we associated with hereditary diffuse gastric cancer, highly penetrant hereditary diffuse gastric cancer. People who would have almost 100% development of gastric cancer by the age of 40, diffuse cancer so that they were often spread to lymph nodes and other places early on. Women who carried this also we knew had risks of lobular breast cancer. So again, kind of like the P53 gene in the hereditary world, this was a gene that we thought of as having a very strong phenotype that you sort of couldn't miss if it was sitting in front of you. But again, what panel testing of lots of patients has shown, and these CDH1 genes tend to be on both the hereditary breast and the colon panels, is that, again, this phenotype looks like it's going to end up being somewhat different than we used to think it was. We're finding a lot more families that have just breast cancer in the family and are carrying these genes. There's no gastric cancer to be found. It's not always lobular breast cancer anymore, although it still is primarily lobular breast cancer. We found also that the mutation type, whether you have a missense mutation versus a truncation or an insertion deletion, seems to have an effect on the phenotype in the family, although those data are still evolving. Interestingly, we're seeing that carriers may also have risks for colorectal cancer, and that was kind of something that was always a suspicion before, but certainly testing now is bringing that out. And a really interesting paper, again, in JAMA Oncology from Hansford's group, looked at families that were these classic CDH1 families with hereditary diffuse gastric cancer, sequenced a whole bunch of other genes and found mutations in beta-catenin and in BRCA and Putz-Jaeger. So again, I think what panel testing is doing is really expanding our understanding of not only the syndromes, and then once we test across a lot of different genes, finding that there are actually other genes that may overlap, and expanding our understanding of the phenotypes associated with the mutations. So this kind of leads me into this multi-gene panels, which is the last thing I'm going to talk about here. Next slide, please. So again, these multi-gene panels, I've been muttering about this now for the last couple minutes. This approach to testing people for hereditary risk was a couple years ago, at least at big academic centers like Fox Chase and other places. People were nervous. Does it make sense to test a woman with early onset breast cancer for 15 or 20 hereditary risk genes? Are there cons to doing that? Are you potentially going to find mutations that aren't related to the risk? Fast forward now 2 years, despite all of the reservations of that approach, I'll have to say that this really has kind of evolved very much, or is evolving, I think, into the standard of care, because the reality is, for any diagnosis, whether it be breast cancer, ovarian cancer, sort of, I think, the poster child, but colon cancer as well. For any of these tumors, there are frankly multiple genes that make up part of the piece of the pie that could be related to hereditary risk. So to try to plot along gene by gene, which is what we used to do 5-6 years ago, it takes multiple months, bringing patients in multiple times. They get tired of it. Frankly, sometimes people would die before you got done testing all the genes. Whereas now you can test a panel of, again, 30, 40 genes. One of the groups has, I think, a 70 gene panel out. So there are clear advantages and potentially disadvantages. It's much more cost efficient. Generally, there's one price to the insurer, roughly about $4,000 to $5,000. It's more time efficient. Cancer patients don't have time to waste, and they don't want to come to the genetics clinic 10 times to get tested. The breadth of testing is improved. You'd be stunned how many patients who were like, this has got to be a BRCA mutation, and then we find that they're PALB2 or there's something else that we wouldn't have even probably tested 4 or 5 years ago. And that helps inform the family. And then, again, patient satisfaction. Patients generally, if they're going to go through this stuff, they want to do everything. They don't want to, tiptoe through the tulips. They want to just find out what they have. The disadvantages, though, are certain. There are insurers are out there sort of dictating what we can and can't do, and they say, why are we paying for each additional gene? This is expensive. Patients are, unfortunately, on some of these panels getting tested for genes that are probably somewhat irrelevant to their diagnosis. And when you find mutations or variants in those genes that you can't explain, it can create a confusing picture for a patient and for a doctor. We don't have the guidelines to support the management of a lot of these genes. We have great BRCA guidelines. We have great Lynch guidelines. It starts to get really gray and thin. After that P10, we have great guidelines. But, so that's a problem when you're finding mutations in BRIP1 and BARD1 and all these other genes for which that we just don't have data to support what we ought to actually do with the mutations. And that kind of gets at this idea also of unanticipated findings. Some of these panels are very general, and so you're testing the young breast cancer patient, or should I say, let's say the young colon cancer patient with a panel, and you find they have a BRCA mutation. Is this related? Is it not related? Clearly that's not the information they wanted to get, and it creates a lot of confusion, and it makes the counseling very difficult. Next slide, please. Deb Cragen showed this nicely in a study that she did, where she paired with one of the big commercial testing groups, and these were patients who were tested because of hereditary colorectal cancer. As you can see to the right, many of the patients had Lynch syndrome. Those are the Lynch syndrome genes in green at the top, as one would expect. Some patients had other genes that the doctors didn't expect. Some had APC, which would have been expected, but SMAD4, which is juvenile polyposis. Again, a few years ago, we would have generally never tested an adult for that. Putz-Jaeger is the STIC11 gene, MUT-YH, P53, like I just brought up. But then some patients had these, breast cancer, mainly breast cancer-associated genes like P10, CDH1, CHEK2, and these were unexpected, but yet clinically relevant mutations, and mutations that people should know about if they have them. So, because there are things they can do about them, and their family can do. So, again, this could be seen as sort of one of the advantages of this, even though you're creating information that patients didn't expect. It's clinically relevant. Next slide, please. Our own experience, with panel testing, and again, I would say, 5 years ago, if you'd asked me this, I would say this might have made up 10% of our practice at this point. In reality, I polled my genetic counselors before I came down yesterday, and probably 80% of the patients, if not more, that we're testing now are getting some sort of large multi-gene panel. So it's almost taken over our practice. So some of our most frustrating cases, these early onset colon cancer patients who are popping up with BRCA1/2 mutations, is that causative? Is it just random and not related? It's unclear at this point. Most of the studies have not shown an association. So maybe these are just happen chance. ATM mutations that we know are associated with pancreatic cancer, but frankly we have a family where we've probably tested 15 people in the family because an ATM mutation was found in a young person who got tested because their parent had passed away from pancreatic cancer, and lo and behold, after all this testing, we found that actually the person, the parent who died of pancreatic cancer was actually not even the carrier of the ATM mutation in the family. It was actually the other parent. So, ATM mutations are actually quite common in the population, and maybe this was just, again, a carrier, a family of a mutation. But I think there have also been some victories in places where we've said, okay, this has really changed care and made things better. So we had a young woman who had come in who had an early colon cancer, early polyps, and again, we did the usual APC, Lynch, didn't find anything. Well, it was right around the time that panel testing was becoming more available, and BMPR1A, for those of you who don't know, is a juvenile polyposis gene, and we actually did find a mutation. And when the history was sort of better explored and went back, we found that the family history was really consistent with this. It's just it was a small family, not a lot of branches on the tree. The other thing that, the other family that I think we really made a difference, and I'm going to show you a slide in a minute, was a family with polyposis and early colon cancer, very penetrant family. Next picture slide, please. So this family, as you can see, this young woman had come to us. She was 40, had had colon cancer the year before. She had two sisters who had both been diagnosed with early colon cancer, lots of polyps, many cancers as early as in the 20s in her family. And we had done, she was one of these people who had come to us. We had done APC testing, didn't find anything. Then when MYH came along, we did that, didn't find anything. Just to be safe, we did Lynch testing, didn't find anything. So we had known this woman for probably 3 or 4 years, couldn't explain this, and she was, of course, terrified for her own children and her nieces and nephews. But then, lo and behold, via a panel test, next slide, please, we found that ultimately this woman did have a POL-D1 mutation, and ultimately then other family members have been able to be tested for this, and we've been able to distinguish who had this or not. And frankly, had this not been added on to one of these multi-gene panels, we probably would not have found it for a while, because that would not have been top on my list. So anyway, these things I think are important and are changing the way we practice. Next slide. So in summary, MSI high, again, as I'm sure you've heard a number of times today, is certainly a new therapeutic target in colon and GI cancers. And then there are these other targets like BRCA in the AZ Polo trial, which will also be very interesting. And it'll be interesting to see if this idea of a maintenance therapy in pancreas cancer that targets BRCA could actually buy some people some additional time. There are some exciting new genes like POL-E and POL-D1. We're still learning a lot about these. They have broad phenotypes. We're not quite sure how prevalent they are right now, but it will not take too long, I think, to figure that out. But then there are also some very exciting older genes that, because of panel testing, we're learning a lot more about. Tumor genomic profiles, like I said, they will likely soon become standard of care for patients with tumors, but the hereditary risks, as ASCO is telling us, need to be addressed, and we have to figure out how to do that in an efficient way. And then germline panels, lots of advantages. Patients want them. Frankly, we're using them a lot more, but there are disadvantages. And so we have to kind of continue to evolve the field to understand how to manage people best. That's it. Thank you very much. I'll take questions.